Hey, let's talk, Dr. Burns, about we just had Dr. Waskowitz on. He did 8 surgeries today. You probably have to do a little bit more when you're doing a total knee replacement or a hip replacement. How long is a typical replacement on a joint?
So surgery for that, all in the operating room is about 2 hours, but that's everything included from kind of wheels in to wheels out. So that involves certainly anesthesia, positioning the patient, prepping for surgery, doing the operation. Every patient wants their wound closed, so we throw that in for free, and then we reverse all that stuff.
Oh, that's great. So nice of you.
Yeah.
But how about putting in the parts and stuff like that? I mean, you've got to be really precise and stuff. Are you using robotics, or are you just doing it by hand?
I am the robot, so
Okay.
I don't.
I've
gone through robotic training, and it has its pluses and minuses. But I think experience is the number one thing with all of this stuff, and knowing where it needs to go for an individual patient, which you can plug numbers into a computer, but the computer can't think in the ways that the doctor needs to think about how the spine and the pelvis move together for a hip replacement, and how just the mechanics of the joint.
So I know a lot of people in my life now, my mother included, just had a hip replacement. And, they have seen maybe their parents or people older than them get hip replacements long ago. The conversation has changed a little bit because of what you're saying. Like back in the day, it was a lot of post-op and a lot of rehab. Nowadays, people are off and running. I don't want to say that.
Yeah.
Off and walking.
Walking fast.
Walking
we don't like them
fast,
to run.
Right. But you still need to do rehab. And this is what I keep on trying to yell at my mom. Like, you got to be doing range of motion stuff. You got to be doing stuff just to get that back to normal, right?
Absolutely. But also, probably, there's been a huge implant development, right? The implants themselves are so much better than they used to be. One of the things, if you go back in time 20 years ago, wear rates and wear issues were the number one failure mechanism of joint replacement. It's nowhere close to the number one failure. You're putting parts in people that you expect to last the rest of their life, even if they're in their 50s now. I'm a firm believer, hugely biased person, right? I'm a hip and knee surgeon. Total hip replacement is probably the best operation in the world, right? Obviously, slightly biased opinion, but
why don't I get mine done then? Why don't I get mine?
It doesn't make you better than whoever you believe made you, gave you at the start. But I think a hip replacement it's a grade A operation. I mean, patients will forget they had it done, and you can't get a higher, kind of level of satisfaction from a patient or a higher compliment as the surgeon from someone saying, I don't even think about it at all, right? I mean, that's the ultimate thing you want to hear from a patient is, I don't think about it at all. Or I forget which one is my,
right,
ceramic and plastic hip versus my, God-given one.
Talking to Dr. Jeffery Burns, hip and knee replacements. Good friend of the show, Fred Lynn, just had both of his knees replaced. He played football at USC.
About time.
Played in the major leagues for about 15 years as an outfielder and stuff like that. But my teammate, Joe Oliver, who is a lot heavier, he's big like me, had both of his knees replaced. Is it different? Like Freddie's probably 170 pounds. Joe's 270, maybe 300 pounds. How difficult is it depending on the size of the patient and what kind of hardware you put in them?
The size of the patient certainly dictates some of the complexities involved in an operation. There's no way around it, right? You operate on a 110-pound, 75-year-old female. Those tissues are relatively mobile. It's a very easy dissection. That operation takes, probably half the time of doing a 275-pound, former football player. In terms of implants, really knee replacements are a little different, especially now. We're looking at newer technologies for cementless devices, which is, pretty much standard of care in hip replacements. We use cementless implants. Knees were traditionally done with the cemented technique, but younger guys.
Can you explain that?
Yeah.
So,
Is that around the mechanism?
Dumping cement inside somebody's knee?
I don't think it's regular cement. I think it's surgical cement.
Yeah, we get a good deal on it from Home Depot. No,
Okay, good.
It's a little bit different.
Quikrete.
Bone cement is actually kind of the same chemical composition as like plexiglass.
Okay.
It's polymethyl methacrylate. It's more like a grout than a glue. The bone is porous, so when you put in like the metal parts of the knee replacement on your thigh bone, your femur, and your shin bone, your tibia, you would traditionally cement those metal pieces into the bone, and that bone cement interdigitates with the porous nature of the bone. And if you're relatively small build, if you're more mature, as we would say to an older female patient in the office, right? So mature we're replacing parts of you that a traditional cemented implant is going to be great. And if you look at, and that's also associated with the body mass index, right? You're talking about the size of the patient. The data clearly shows that body mass index below 35, cemented implants have a great track record. We're really looking at the bigger guys, right? Especially the bigger, younger guys. So people who are getting their knees done in their late 40s or early 50s, and they're 6'2", 275 pounds. If you can get a biologic fixation, so cementless devices are dependent on the bone healing to the implant. So the metal piece is impacted. The bone has to be strong enough to hold that piece without any sort of bone cement fixation right away. But then over the next couple of months, the bones grow onto the implant. Once that happens, it's a biologic permanent fixation. So you get rid of the potential failure mechanisms of bone cement 20 years from now. Just like a sidewalk cracks outside, right? Eventually fatigue failure, that's what you're trying to get rid of, that another potential mechanism for needing a revision, a redo.
I find this fascinating.
I don't even know bones grow like that.
I think
bones are constantly
so when I had the
growing.
plate put in, the reason why it took a couple of months, the bone has to set onto the screws.
Couple of months
grows
seems fast.
onto the screw.
Well, bones are the only
It grows
tissue
back.
bone heals with bone.
Yeah.
Every other tissue, if something happens, you get scar, right? Even if you have a heart attack and the part of your heart muscle dies, you don't get new heart muscle. You get scar tissue that takes the place of that. Bone is unique. It heals with itself. So in that plate you're talking about, like, the bone has to heal across the fracture site.
Right.
The bone cells cross it and they lay down new bone, and the plate is there to hold it in place and make sure that
so
process
it can
can happen.
I remember looking at the CAT scans and whatever, and you could see it coming together and then being healed. It's an amazing process.
How many football players have you seen in the last decade? I'm just wondering. Are football players coming in for hip situations?
We see a lot of athletic injuries in the past.
Well, I'm wondering because the NFL is outlawing the hip drop tackle, and that's basically like falling on the back of your legs as you're moving forward, and it's supposed to reduce a lot of knee injury plus a lot of hip wear and tear over the years. It's a new thing. We'll see, what happens, if it's going to reduce injury or not. But I always found it kind of a freaky thing when somebody had a hip dislocation in the game of football, really any sport, but it seems a lot more common than I knew.
Yeah, and we see hip dislocations more commonly as motor vehicle accidents. So, I mean, your own hip dislocating is an unusual event. So that's a high energy mechanism injury. So usually it's a car accident or a fall from a large height. And when that happens, there's cartilage surfaces that bang into each other. And I've seen plenty of patients who then need a hip replacement, not usually right away. It all depends. If they break their bones too, if they have a fracture of the socket, well, that can lead to rapid osteoarthritic disease over a year or two. But we also see it, like 20 years ago, I was at a frat party and I fell out of a window. I mean, I have a patient that's the story.
Oh, that wasn't you. Okay,
no.
You're talking as a patient. Okay.
Yeah, let me clarify.
Yeah.
And
I just know you as a party animal back in your Penn days.
We cleaned that all up. But and then developed kind of what we call post-traumatic arthritis. So probably in that mechanism of injury, the cartilage cells were killed by the trauma.
Okay.
And it doesn't catch up with you right away. It can take decades, but eventually those cells aren't alive anymore and they don't supply nutritions, and that's what and you end up with a hip replacement.
Well, for my mom, and just putting her stuff out there, one of her hips was like totally degenerated, and like it wasn't even a hip anymore. The other hip was perfectly fine, 100%. She played a lot of softball, and maybe that's sliding. Like, she's trying to go in her brain, like, how did this happen to just one side?
I chuckle all the time in the office. Human beings were dot connectors, right? We want to say dot A, dot B, dot C, and everything that happened is got to be connected. Sometimes it's so multifactorial you can't figure that out. She may have had, you form from a single cell and you make a human body, right? What are the odds that process comes out perfectly? So if things are a little mismatched, that's what catches up to you. When human beings live to 40, 50 years old, well, you didn't live long enough to have some of these problems. As we live longer and longer, then having a little bit of a square peg in a round hole, so to speak, right, that catches up with you.
It may have been the first time she's ever had x-rays. on her hips. Is that the case with a lot of your patients? Like, I've never even looked at my hip joints. I've never looked at my own hip joints.
Well, most people don't have like surveillance pictures for no reason,
We should.
right? I mean,
We
no.
should. I want an X-ray every day.
That's how you end up with that. When you start ordering tests, you get results, and then you get problems,
And
right?
you don't want to know all the answers.
Sometimes,
That's
yeah.
right.
I mean, you don't want to know everything about everything because then then you end up having treatments you don't need. So you got to watch out for that.
So yes, like a lot of people that see this picture for the first time, that is their first X-ray.
Yeah, and sometimes you're amazed that there's the power of denial, right? People are like, "Oh, this isn't so bad. It's going to get better." It's and I mean, my first patient this morning, he can't bend his hip to 90 degrees to sit like we're sitting right now. So like at some point you have to wonder like, how do you justify that in your mind that I can't sit down, but that's okay, right? I mean.
I'll live with that pain. We're talking to Dr. Jeffery Burns here from the Bone and Joint Institute. I wanted to ask you, so you go in sometimes and maybe do you have to do another hip replacement of something that's worn out, or the knee, something's worn out, the mechanism is worn out? What's the strangest thing you've come across in your profession where you've gone in and looked at like a 20-year-old knee replacement gadget and been like, wow, that didn't wear well?
I mean, usually I've seen all kinds of things. I mean, we've seen things that are clearly not supposed to be in the.
Well, that's what we want to
the
know.
knee.
Yeah,
I mean, I've seen bits of
Bring it.
things that are from like the equipment, like the trialing apparatus. Bits that clearly are not supposed to be left in a knee, or. So thank God that is very rare.
Do you always tell your patients the truth? Do you say like, hey, by the way, I found like a sponge, or I found like something else?
Well, I've never found a sponge,
Okay.
thank goodness, and I always tell the truth. I'm a terrible liar, but
Seemed like it.
Yeah.
That's one thing. I was just walking in there in the motion lab and stuff, and with Steph Barassa, head of PT around here, and she was teaching me all the cool wearables that are now out there, and it just feels revolutionary for especially young kids and student athletes that can get those kind of baselines to know that kind of information with their doctors in a place like this. And
I mean, it's definitely cutting edge technology, right? And being able to, map out motions.
But that's so new.
But-
Like when we get to your
Yeah.
kind of patients in their 50s and 60s, like that information from when they were 20 and 30 is going to be very beneficial for you.
It's trying to figure out what do we do with it and how can we best utilize it, right? That's the tricky part right now, is trying to sort out, we have the technology, and then how do we use this technology for betterment? Because it can sometimes we're just overwhelmed by the information, right? You get so much information, you're not sure what to make out of which parts of it.
Do I have to wait before I can't sit down? When should be the light bulb?
How much pain?
Right.
Is
What's
it like
the
8
light
out of
bulb?
10? When do I come to you?
I think so. It's all about quality of life. I've always said I wanted to be a quality of life doctor. I don't want to be a quantity of life doctor. I don't want to hold your heart in my hands and decide whether, how to revascularize it. But if your hip or your knee is ruling your life and you limit what you want to do because of your hip or knee pain, it's definitely time to see an orthopedic surgeon.
With that, we'll say goodbye. Dr. Jeffery Burns, thank you so much for your time. You guys are fascinating. We love being here.
My absolute pleasure.